So because I don't have anyone home with me right now to film a maternal assessment, I'm just going to go ahead and talk you through what I would do if I were to give one in a hospital. So first, that would just start with me gathering my supplies, which is going to be my stethoscope, gloves, tendon, hammer. I'm going to get all of that together. And when I walk in the room, I'm going to do, the things we do every time we come in. I'm going to provide patient privacy by either closing the door or pulling the curtain. I'm going to introduce myself to the patient. I'm going to say, hi, my name is Kenzie, and I'm a student nurse from Indiana Wesleyan University. And I'm just going to inform them what I'm there to do that day. So I'm going to say, hey, I'm here to perform your postpartum assessment just to check everything out and make sure that everything is going well. At that point, I would confirm that I have the right patient. So I would ask for name, date of birth on the mom, and then just if they have any allergies or anything like that. And before I do anything, I'm going to perform hand hygiene. And then, in most places that we would take vitals and then just make sure that those are within normal limits. And then before I start, I would raise the bed just to make sure it's at a working height for me to keep me safe. So to start, this is going to be like a head to toe. So I would start with the patient head, or I guess just some general questions about how are they doing, how are you feeling, did you sleep well, if they had been there for multiple days, asking them that. And then we're going to make sure that we're asking them about any pain that they're in after giving birth. You're going to be in a lot of pain, so we're going to ask them about that. So we're going to ask like what hurts, like what makes it worse, what makes it better. Is it like a sharp stabbing pain? Is it a dull aching pain? Is it all over? Does it radiate? Does it start somewhere and move to somewhere else? That kind of stuff. And then we're going to ask them to rate their pain on a severity scale. So like 0 being the no pain at all and 10 being the worst pain you've ever felt in your whole life. What does this feel like for you? And then we're also going to ask about like timing of the pain. Does it go away? Is it constant? That also kind of goes with how is it feeling, like or like what causes it? Is it only just like walking, or is it always like even when you're just sitting down? And then we're going to ask them if it's affecting like their day-to-day life, if it's affecting their daily activities of living. Is it making them hard for them to shower, to clean themselves, to do any of that kind of stuff, so we can help them with that. And then even after you give birth, you can have preeclampsia. A lot of people will think that it'll just go away, but even afterwards, we have to be screening for the symptoms of it. So we're going to ask if they are having any blurred vision, if they're having any headaches, if they're seeing like any floaters around them, or if they're having spots in their eyes where they can't see anything, because those are all signs of preeclampsia. And so we want to be monitoring for that even a few days after they've given birth. And then moving down from your head, obviously we asked all those questions and we assessed for preeclampsia. Then we're going to move down to the heart and lungs. So obviously you're going to check the 5 heart sounds, ape to man. So you're going to, sorry, these ones are really hard for me to remember. So you do all 5 of the spots, moving down, ape to man, and then we're also going to auscultate the lungs in a Z pattern, making sure that we are hearing all of the different lobes of the lungs so we can verify that those are clear and that there's nothing going on there. After a woman gives birth, it's common for people to get pulmonary embolisms and that kind of stuff. So we're just going to check in on those lungs just to make sure that they're okay. And then in that same region, we're going to ask them about their breast, especially if this mother is breastfeeding. It's going to be really important to check on that. So we're going to just ask them like, hey, how's that breastfeeding going? Is it going well for the baby? Is it especially tender for you? Are you having excessive pain? And are your breasts starting to fill and feel heavy? That kind of stuff. And if they are breastfeeding, you want to make sure that they're wearing a loose wireless bra, because that's going to encourage the breasts to make milk. If they're not breastfeeding, we're going to encourage them to wear a tight wireless bra. So one thing that we learned is we're going to suggest that, hey, maybe you should wear a bra that fit you before you got pregnant. So when your breasts weren't as big, wear that, and that's going to stop milk from being produced, as well as if you need to, or supplement that with something else, you can put cold cabbage leaves. Those are also known to stop milk production. And then we're going to inspect the nipples and the breast area. We're going to make sure that the nipples are soft and intact, that there's no lesions or anything like that, and that there is colostrum being expressed, that something is coming out. Eventually that'll turn into full-blown breast milk, but for the first couple of days it's just going to be that colostrum. And because my phone won't let me send long videos, I'm going to stop that here, and I'll send you a part 2 with the second half of the assessment. Okay, so for part 2 of the assessment, we're going to start with the upper extremities, which is going to be the arms. And so we're going to start by checking bilaterally for those pulses, and we're going to rate them from a 1 to a 4, just like we do on any patient. And if they have an IV site, which they might not, but most of the time if they are in a hospital, they will, we're going to go ahead and check that IV site, make sure that it's not red or inflamed, that there's no tissue breakdown, make sure there's no swelling or tenderness there. And then if they're receiving IV fluid medication, we're going to make sure that we check for those 6 medication rights, which are going to be right drug, right dose, right route, right time, right patient, and right documentation. So we're going to check for all of those if they're receiving IV drugs, and if that looks good, then we can move down to the lower extremities, where we are also going to once again rate and grade those pulses. So we're going to find them on the lower extremities as well, and then we're going to also check for edema in the lower legs. Chances are these women have probably been laying down for a while if they just gave birth, so we're going to check for that. We are also going to assess for a deep vein thrombosis, a DVT, and so we're going to check that. And when we're looking, we're just going to we're going to do Holman sign. So we're going to look, and we're going to push their foot back and hold it, and if they're feeling pain in the back of their calf, that could be a sign of a DVT. And we're also going to check for any heat or redness on the leg, and we are also going to assess their deep tendon reflexes. So that's why we have the tendon hammer, and when we do that, we're going to just hit it on their knee. It's assessing for that reflex. And then we're also going to assess for clonus. So when we do that, if my hand is the patient's foot, you tell them to relax it, and you're going to just wiggle it around as they're relaxing it, and then you push it back. And if it bounces, that's going to be a sign of clonus, and so you're going to want to check those bounces, and that could be a sign of some issues if they do have clonus. So we're going to check that as well. Moving on to gastrointestinal, we're going to ask them when their last bowel movement was. Have you had a bowel movement since you've given birth? Was it before then? Just to make sure that everything is working right in their gastrointestinal system. And then we are going to also listen to all of the bowel sounds. So we're going to listen in all 4 quadrants, make sure that everything is active. And then we're going to palpate their liver in the right upper quadrant. And so we're going to do that, and we're just going to ask them, is this painful? Is it tender? Does it hurt when I press here? And then if they've had a C-section, this is also when we're going to go ahead and inspect that incision. And so we would look for Rita. So we're going to check for redness, edema, ecchymosis, which is going to be bruising, drainage, and approximation. So if any of those things don't look right, we're going to want to record that so somebody else can come look at it if they have to, one of their physicians, but we're just going to check that all of that is intact. And then next we are going to assess their urinary tract or their urinary system. So when we do this, before we do it, we're going to make sure that we put on gloves just to keep everybody safe and clean. And then we're going to ask them when the last time they urinated was. Are they having any problems urinating? Does it burn? Are you going an excessive amount? Just frequency. So we're going to ask them all of that. And then if they do have a Foley catheter in, we're going to check that and note the color and the odor of the urine, and then just perform that Foley care if they need it. And then we would move on to their reproductive system while we are down there. So while we're down there, we're going to assess for the lochia. And so we're going to look for amount, color, and if there's a lot of clots, and when the last time their pad was changed. Because if they have a completely soaked pad and it was only an hour ago, we might want to be watching that a lot closer. So we're just going to check for that kind of stuff. And then we're also going to record that. And then we are also going to check their fundus. So that would be giving a fundal assessment, checking the location of the fundus, if it's firm, and how much lochia is expressed, and if it's normal for the amount of time it's been since the birth. And then we're also going to do, next we would roll the patient over so we could do an incision and a posterior assessment. So we would roll the patient to their side and we're going to have them just roll over. And then we're going to check them for hemorrhoids. It's really common for pregnant women to acquire hemorrhoids, so we're going to check for that and inspect. If she gave birth vaginally, we're going to either check that episiotomy, if she was cut on purpose, or if she had a tear or a laceration, we're going to check that, and we're going to check it for Rita once again. So redness, edema, ecchymosis, drainage, and approximation if she was sewed back up that way. And then if she received an epidural, we're going to check that site and we're going to look for bleeding, if there's a major hematoma, if there's any skin breakdown from where that was inserted. And so we're going to check that out while we have the patient rolled over. And then lastly, we would just make sure when we were doing this, if we were giving the assessment to you in real life, we would just verbalize level of consciousness throughout it. So the patient would most likely have an appropriate level of consciousness, be alert, awake, and she would probably be speaking about appropriate things. And then I would make sure to remove my gloves before helping the patient get comfortable, and then lower the bed and put the side rails up to make sure that the patient is safe, and then just ask them if they need anything, if there's anything I can do for them, making sure that the call light is in reach before I leave. And then yeah, that would conclude my maternal assessment. So this is my newborn assessment video, and while I couldn't find a baby doll, I did find a koala bear Build-A-Bear. So I'll be using this for some of this stuff. But the same way we started the maternal assessment is kind of how we're going to start the newborn assessment. We're first just going to walk in, and first we're going to ask the parent if it's okay for us to assess their child. We're going to gather our supplies. In our case, this time it's going to be a pediatric stethoscope that we're looking for, and then gloves as well. We would also then take the vital signs of the baby when we came in and note and make sure that those are normal and within range, and then document. And then we would identify the baby via the mother. So we would say, hey, like, this is your kid, right? Like, could you give me name, date of birth, that kind of stuff. And then we would once again verify the baby via their ID band as well. And then before we were to touch the kid, we would make sure that we were providing privacy for the patient. So we would either close the door or pull the curtain, and then we're also going to perform hand hygiene, and then we would check for the info on the ID band. First thing, you can ask the parents just about the sleep-wake cycle, like how are they sleeping? Are they waking up when they're hungry? Are they sleeping for a really long amount of time? Are they just awake and asleep? So we're just going to check for that. And then we're also going to check for their muscle tone. A baby shouldn't just be floppy. A lot of times they're somewhat flexed all over their body, and they pull in their extremities close just because that's what they're used to. So we're going to check and see that that's the case, because if a baby is really floppy, then that could suggest that something is wrong. So first what we're going to do is you're going to assess the head of the baby. So obviously the head of the baby just went through a lot of trauma coming out, so we're going to check, and so we're going to check the skin on the head. We're going to check that it's intact, that there are no lacerations. Chances are there might be some bruising around the baby's head, which would be normal. It did come out of a very small area, but we're going to check and note that just for future reference to see if that goes away, and also just to protect the parents so nobody thinks that they're doing anything to their baby. So we're going to check that, and we're also going to assess their sutures. So when we're checking, we're going to check all of the different sutures, and they're either going to be approximate, overlapping, or split. So they're either going to be just touching each other, they could be overlapped because the baby's head had to squeeze through a small area, or they could be split where they're not touching each other at all. We're also going to then check the fontanelles, and we're going to check to make sure that they are normal, soft, and flat. If they're sunken in, that could mean that the baby's dehydrated. If they're bulging, that could mean that the baby has excess fluid in their head, on their brain. So we're going to want to check for that, and we're going to check the anterior and the posterior fontanelle and check for those. Next, we're going to check for any swelling of the head. If it's going over suture lines, that's going to be, I cannot pronounce this, caput succedaneum. I have to look at it because I can't even remember the word. Caput succedaneum, and that goes across. And then if it is staying on one side, that's going to be different. And then cephalohematoma is going to be an accumulation of blood on the head, and that's going to look like a bruise, and those usually don't cross suture lines. Next, we would check the baby's eyes. So we would check and make sure that the placement is normal and that it is symmetrical. And then we're going to just check and see if there's any subconjunctival hemorrhage. So we're going to look, and that would be like pulling the baby's eyelids down to check and see if there's any like burst blood vessels, and we're going to make sure that there's no discharge coming from the eyes, as well as acknowledging that a baby's eyes are probably going to be swollen just because of the trauma from birth. Next, we're going to assess their nose. Obviously, this nose looks a little different, but it's looking good because it is midline. And we're also going to check for patennaires, so that's going to be feeling for breath and maybe plugging one and making sure that they both are able to breathe. They're able to breathe through both of them. And then next, we're going to assess the baby's mouth. My koala bear does not have a mouth, but we would look around and we want to check for circummoral cyanosis, and we're going to check to make sure that it's not bruising and that maybe it is circummoral cyanosis, because we're going to want to chart that differently. Circummoral cyanosis is common in babies just because they are still working on getting that oxygen around your all around your body, so that little blueness around the lips is common. And then we would then apply our gloves before we did this next part, and we would assess the baby's gums in the mouth, in their palate, and we're going to check and make sure that it's normal, just looking to make sure that it's pink, it's moist, and that it's intact. This is also where we check a lot of times you can tell with a baby who has cleft palate, but you're also checking for that just to make sure that it is there. Next, we would assess for the suck reflex. So especially this is really important for babies who are breastfeeding or even bottle feeding. It's important that they're able to work that suck reflex. So we're just going to see if they suck on our fingers, and if they do that. And then we're also going to assess for the rooting reflex. So that's where we would drag our finger across the baby's cheek. And when we do that, the baby's head should turn towards where we touch, so they should move their head so they could do that, and that just shows us that they do have a good rooting reflex. And then at this point, we would remove our gloves. Once again, my phone won't let me send large videos, so I'm going to pause it and I'll send you part 2. So for the second half of this newborn assessment, we would then move down to the baby's chest area. So first thing that we're going to do when we're assessing a baby is we'll check their clavicles to make sure that they are intact. If a baby's if a baby's shoulder gets stuck and they have shoulder dystocia, there is a chance that they might have had to break a baby's clavicle to get that baby out of the birth canal. So we're going to check and see if those are intact and make sure that those are. And once that is looking good, then we're going to auscultate for their heart rate. And where you're going to do that is where you can hear it just the best. You're going to find the PMI where you can hear it the best, and we're going to auscultate there. And then we are going to auscultate the 5 heart sounds, ape to man, once again like we did on the mother. At this point, you would then assess for respiratory sounds or any respiratory distress, which is going to be any nasal flaring, grunting, subcostal retractions. Mind you, a baby hasn't been breathing on their own for a really long time, and while they were practicing breathing in the womb, it was actually fluid, so sometimes it takes them a second to adjust once they are born. So we're going to check and see for any of that sort of distress. Next, you're going to assess their arms, and so then we would find their brachial pulse, which is a little different. We're not going to find it down by their wrist. We're going to go up in their upper arm above their elbow and check for their brachial pulse on both sides. And then when we do that, we're also going to then check for their grip reflex, putting our fingers in their hand. A baby should grip it. And then we're also going to check for acrocyanosis, so any bluing of the hands and fingers, which once again, just like circummoral cyanosis, is really common in a baby for the first couple of days. So we're going to check for that and see if that is present. And then lastly, when you do the upper extremities, at this point, this is when we do the Moro reflex. So this is kind of like their startle reflex. So either way, one way you could do that is if your baby is laying flat on the bed, you can try to hit your hand next to their head and startle them. Or another way that you can do it is we would take their hands, you would usually use both of your hands, but you would take their hands and lift them just barely off the bed and then drop them back down. And a baby's hands should flare out like this and their arms should tighten up. So that's how you know that they have a positive Moro reflex. And then next we're going to move to the baby's abdomen. So we're going to palpate the abdomen and we're just going to check to make sure that it's normal, it's round, it's soft, it's not distended. And then we're going to auscultate the 4 quadrants, and we're going to listen that they're having active bowel sounds in all of them. And while we're doing this, we're also going to check for the umbilical cord. So when you're looking, you're going to check that it has those 2 arteries in the 1 vein. And then we're also going to check that it's clamped, odorless, and it has no like intestinal structures coming out of it or attached to it. So you're going to just check to make sure that we're also going to just assess for like infection and making sure that it's drying out and that kind of stuff, because that's really important for a baby. And then once you move on from that, at that point you would assess the baby's genitalia. So if it's a female, you're going to check and you're going to notice and you're going to understand that because of the traumatic birth process, the female genitalia might be swollen. Also because they were receiving all those hormones from their mom when she was pregnant, might be swollen. The mucosa, the vaginal mucosa, should be pink and moist, and also understanding that there might be some secretions once again due to the maternal hormones. And then if the baby should have their first passive meconium by the first 24 hours. If your baby is a male, you're going to check and you're going to see if the testes have descended. They should be descended into the scrotum once the baby is born. And at a full-term male, there should be rugae present on a male infant. And then we're going to check the urinary meatus. We want to check and make sure that it is midline on the penis. And then if there's any deviation, we want to make sure we note that so we know if they're checked later, it doesn't mean that it's changed. It's just always been like that. There shouldn't be any discharge or inflammation on a baby's penis. Then if they've had a circumcision, then a baby's might have some inflammation going on, but that's just due to the surgery. And then their meconium once again should pass within within 24 hours. Same as a female's. Then next we would assess the infant's legs. So with the infant on the back, we're going to lift up their legs like so. And so when we do that and we push them back, we're going to assess for symmetrical thigh folds. If they're asymmetrical, that could suggest that there is some hip dysplasia, or that there might be an issue with the alignment of the baby's hips. And then we would also assess for the Babinski reflex. So we would take our finger and we would run it up the baby's foot. With a baby, their big toe should pop up. That is normal for a child, not normal for an adult. And then we're going to also assess for their plantar grip by placing our finger or our thumb in the middle of their foot and hope that their toes, kind of curl around our finger. That's going to be positive for that. And then a full-term infant should have lines on their soles of their feet. So we're going to check for that as well. Then we would assess the infant's spine. So we're going to turn the infant over, and you can hold it in a variety of different ways. We're going to assess that the spine is vertical, and we're going to check to make sure that it is midline. But this nice little handy dandy koala has a line that we're going to pretend is the spine. So as you can see, it is vertical and it is midline, and we're going to assess that the spine can easily flex while you're holding the child. You might just bend their back a little bit, move their butt, make sure that the spine can easily flex. And then we're going to check for sacral dimples as well on the infant. And then we're going to check out for a hair tuft as well, so we can rule out spina bifida. And then we're going to assess for the presence of Mongolian spots. Those are going to be more common in our African American babies or our babies of color, but we're going to check for those because those can look like bruises, but they are common on children. So we want to check for that once again, just to keep the parents safe and make sure that and also keep ourselves safe and make sure that nobody thinks anything of the bruising on an infant when it's just a Mongolian spot. So we're going to check and make sure that that is noted on the chart. And then when we're done with that, at that point we would just re-swaddle the infant in their blanket and either return to the mother or return to the bassinet or cradle, wherever it was. And then we would just once again just make sure that the mother had everything that they needed and just check in with them before we left, and then we would be done.